All right. Good morning, everybody. Thank you so much for joining us on a bright and early last day of conference. So we appreciate you taking the time. My name is Namita Jayaprakash. I'm an EM intensivist based out of Henry Ford Hospital in Detroit, and I'm very excited to have my expert panelists here join us, because what we're going to talk about today is critically ill emergency department boarders. The struggle is very real. And how do we tackle the current state? And we're going to talk through a little bit of like brainstorming, innovative solutions, and you're going to hear about different models that have been implemented. We don't have any disclosures. And our objectives are really to start thinking about how do we factor in and consider design and implementing. We're going to touch upon some inpatient outcomes on various different models. We'll hopefully get some time to talk about how to engage hospital leaders in the conversation, some of the challenges, some of the barriers, and really to kick off things, I just want to really talk about what crowding and boarding, what it means in today's world. So between 2006 and 2014, the number of critically ill patients presenting to our emergency departments in the United States rose by 80%. Concurrently, there were really a minimal number of changes in the availability of ICU beds. And if anything, those ICU beds have gone down. And so you've got these increase in ICU admissions. You don't necessarily have a proportionate increase in the number of beds. And so that ratio inequality is really backing up into the emergency departments. And it is coming to a head in this national crisis we're in right now with crowding and boarding. For a critically ill patient who presents to the emergency department, they arrive, there's a period of resuscitation and initial stabilization. There's the decision to admit to the ICU. But is there an ICU bed available? Well, there are many factors that can impact the availability of the ICU bed, and that just backs up into that issue of boarding we talked about. And these could range anywhere from there's a delay in the ICU discharges because there are no hospital beds available in the general wards, so you've got an exit block. It could be that maybe the beds are available, but there aren't cleaning resources, and so the type of cleaning for a complex ICU patient with multi-resistant bacteria is more extensive than a standard clean. Perhaps it's that there is a need, you're a regional center, so there are many critically ill patients coming from various other hospitals, so transfers into the ICU that are limiting access for patients presenting in the emergency department. And then there's, of course, the decompensating patient on the general floor. That might take priority. The perception that a critically ill patient managed in the emergency department, but us skilled resuscitationists, that's a better place than a decompensated patient on the floors. And so the consequences of boarding are really the need to deliver longitudinal critical care interventions in the emergency department beyond that resuscitation phase and stabilization phase. Though, what next then? Well, perhaps in the delivery of those interventions in the ED, perhaps there's another ICU-capable hospital that the patient can be transferred to. The ICU bed becomes available, and then there's a transfer to the ICU. Or the patient improves because of the delivery of care in the ED, and now they're downgraded, and now they no longer need the ICU bed, and they're going to the general floor. So what we really want to focus on at this point is that period where you have to deliver the critical care interventions in the emergency department because of that consequence of crowding and boarding. And there have been various different models described. So the ICU without borders model, this is effectively the intensivist team going to the patients. And this can include also rapid response teams, medical emergency team, response teams in the hospital. And then there are models that are ED-based critical care delivery models. And these can be further split into geographic models and personnel-focused models. And so what we have is an expert series of panelists. We all work in various different models. And so we're going to share a little bit about our own experiences and our models. And then what we're going to do is open it up to any questions. And we'll talk through some of the challenges and the barriers from our experiences, the impact on outcomes. So to kick things off, I'm going to hand it over to my colleague and let him introduce himself.
Good morning. Thank you, Namita. Thanks to all of you for spending your waning hours of SAEM with us this morning. So it's great to see you all. I'm Jamal Sosner. I'm from the University of Michigan. I'm in the departments of emergency medicine as well as neurology and division of critical care. I'm going to spend a little bit of time talking to you about a couple models. They're both geography-based, ED-based ICUs that I've had the pleasure of being able to help design, develop, and implement. One is at our own shop at the University of Michigan, and the other is at University of Cincinnati, which just opened. In terms of the University of Michigan, we call it EC3, which is the Emergency Critical Care Center. Our guiding principle that we used when we were developing this was to improve access to timely, high-quality critical care by enhancing capacity and capability to deliver this care in the adult ED at U of M. We knew that we wanted to create an outpatient, specifically an outpatient-based ICU that was in the walls of the ED, run by faculty that were emergency physicians first, and also critical care physicians, double-boarded preferably, or if not, with additional training. Our inputs and outputs were going to be the same. We wanted to take care of patients that came through the doors of our emergency department and were stabilized and were subsequently placed into the ICU for that advanced level of care. We did do a lot of modeling at the time because there was no unit to really model ours after, and we weren't sure exactly how many beds we needed to do. So based on our modeling, we knew we needed about somewhere between 8 to 10 beds with an increase in the number of resuscitation bays. We opened our doors in 2015. We were benefited by having a very generous family that had donated quite a bit of money to help us get this off the ground and to continue it running, as well as it was part of a chair package for our incoming chair at the time, whose vision was to create an ED-based ICU. Our unit is 9 beds, set around our resuscitation bays. We have 5 resus bays at the bottom, A, B, C, D, and E, and then the 9 beds are all around the top. We have a centrally located staffing station that's staffed 24/7 by physicians and nurses that are specifically trained in critical care. Over the past 10 years, we've put over 20,000 patients through EC3, and we've had marked success. I won't belabor this slide too much, but when we look at the pie chart, the area that I'll draw your attention to is the blue area, because as with our talk, our goal was to try to figure out how to decrease ICU boarding, and one thing that we've been very successful at is being able to take our patients that came in critical and then downgrade them into a non-ICU level of admission. In fact, 58% of all patients that came through our doors critical would subsequently be placed into a non-ICU level of care, which was a huge win for us. We did publish a paper a few years after opening that looked at our pre and post data, and we were able to show a mortality advantage for all patients in the ED with the opening of EC3, which was a fairly remarkable task. When we look at our value equation, we know that we wanted to increase quality and try to keep the costs neutral, which is exactly what we were able to do. I won't belabor all this. Maybe in some of the question and answers, I'm happy to share some of the successes we've had, but certainly we've been able to lower 30-day mortality. We've been able to significantly lower ICU admission rate, particularly those kind of quick 24-hour ICU admissions. The second geography-based unit that I'll talk about is the Flex ICU. This is the newest one in the country that we know of. It was opened in October and has had some significant successes early on. Very similar model in terms of their vision. They wanted to make it a little bit more flexible than ours and a little different. This is actually an inpatient ICU, and their inputs are a little bit different than ours. In addition to having the vast majority of their patients coming in from their ED and from their hospital for decompensating patients, they also wanted to be able to have a unit that was going to bring in patients from the outside. They were noticing that they had a significant delay in terms of ICU to ICU transfers, or any patient that was sick in any of the area EDs going into an ICU. Many of these patients are still undifferentiated, and so they had a significant stream of patients coming in from other EDs directly into their Flex ICU. In addition, they also wanted to have a novel kind of collaboration with their Network for Hope, which is their organ donation system, so they created an organ donation center within the walls of their Flex ICU. They designed it into a new tower that was being built. They have 12 beds with an additional 5 beds that can flex into ICU level of care if necessary. These are all along the side walls here to kind of bring in ambient light. This is just their main hallway of beds on their opening day, just a very significant and large unit. Their goal was to stay at about a 10-patient occupancy of 12 beds to have some degree of flexibility, and this is since opening. They had a gradual start where they opened up rooms in a tiered fashion all the way up to 12, and then in the last several months, they've been able to keep their goal of about 10 patients census throughout. Their impact has been fairly dramatic in their early months. They've had a 6% reduction in total length of stay for patients treated in their flex ICU. They've had about a 50% reduction in time from admission to bed occupancy for patients coming from the ED. And they've had a significant increase in the incremental number of ED visits they've been able to handle, basically because they've been able to take off all the critical or moderate care patients that were boarding in their ED previously. In addition, one of the other big wins that they've had is their donor care unit data has been impressive. They've had 16 brain dead donors come through their walls thus far since opening, and that's allowed them to increase the number of organs transplanted per donor from 1.92 in the preceding year to 3.8 already in the months since the opening of their flex ICU. So again, some significant numbers in two different kind of geography-based ICUs. From here, I will pass it back over to Namita.
Thank you. So those are the geography-based models, and now we're going to pivot into a little bit more of the personnel-based models. And at Henry Ford Hospital in Detroit, we're an 877-bed hospital. We have 160 or odd ICU beds, and yet our emergency department critically ill boarding time can range anywhere from 24 to sometimes even 72 hours. So our need very much was, how do we support the longitudinal care of our critically ill patients? And what we have is the early intervention team is a consulting service. And so we have board certified or board eligible, either double or triple boarded EM critical care or EM-IM critical care physicians who serve as a consulting service for our high acuity patients in the emergency department. And we are a level 1 trauma center. We work from 2 p.m. to 10 p.m. And when patients arrive to the emergency department, the high acuity patients, they're triaged to our category 1 area. They're evaluated by the primary emergency department team, so that includes an attending, a senior resident, a PGY3, a junior resident, a PGY2. Now, at that point, the disposition is say they're, for example, they're being admitted to the ICU. That kind of kicks off that signal that we're now entering into that longitudinal critical care needs phase. And so that is a trigger for consultation. We've also left the option, though, because we are an incredibly crowded and busy emergency department, and our category 1 area, while it officially has 16 beds, we are often caring for 30 to 32 patients in that area. As you can imagine, you've got these very complex patients. That category 1 team can quickly become quite overwhelmed and have many competing demands. And so the option for the category 1 attending to use their own discretion and consult thus is really to serve also as a support system to cognitively offload the primary emergency department team. So a consult service is available from the 2 p.m. to 10 p.m. hours. The admission process does not change. It is the process is the ICU is contacted. The care does not transition until the patient moves to the ICU. So this is really that support system providing consultant recommendations. I'm going to hand it off now to Dr. Mitarai, who's going to tell you a little bit about a different personnel-based model.
Thank you very much. Okay, my name is Yoshi. I'm EM-IM critical care attending at Stanford Hospital. I'm going to be briefly talking about what the ECCP model is about and the research outcome and how it's actually trying to solve the issues of the boarding. So back in those days, 2015-16 or so, I visited Michigan, and it's a great program. But our place doesn't have a space to have these patients to be cared for in that kind of a designated location, and also didn't have enough patient volume coming through the ED for critically ill to justify those models. So I had to think about, what can I do? Because we do have boarding issues at Stanford. So we have this ED-based intensivist consultation and management models. So we'll talk about a little bit more difference between the Henry Ford and our models in the second half of the talk today. But basically, who is the EM critical care dual train attending? And what is that we provide prompt MICU triage consultations, and if we accept the patient, we have longitudinal management of ICU patients. But beyond this, we also have this other responsibility, which is to provide consultations and admission to all the MICU patients basically in the evening because all these MICU attendings are gone for the day. So we go to all these code blues, supervised procedures, and all these things will be done by us. And the way we do this is ED. It's not going to be designated location. We are like a white blood cell. We go to wherever the patient's needs are and just do this resuscitation in the same ED room, so they don't have to move. Same nurses as well. When? It's going to be 2 p.m. to midnight, Monday through Friday, and there's a reason for that. If you look at the distribution of the patients who gets MICU admission orders and looking at the ED arrival time, it's not flat line at all. So around 10 o'clock, they start coming more, and then because emergency medicine team is going to resuscitate for a couple hours before they call the ICU team, when we come at 2 p.m., we can capture majority of green as well as many of the purple patients. So without having to staff 24/7, which is going to cost a lot of money, we could actually get the most out of the program with this type of time of work. So let's go into a little bit more detail about the program operations. So the baseline, which is the left side of the slide, we have ED team who takes care of the patients, and then they'll call the MICU triage, hey, I have some patient of you to come see. And then they'll see the patient, staff with their MICU attending on call, and they give you the typical binary admissions, yes or no. And then MICU team takes over the patients who are boarding ED afterwards. Stanford is kind of unique because besides the ED nurse, they actually have ECC nurses who are dual trained, who supervise the primary ED nurse. So that's the baseline. And then when we start the program in August 2017, during the ECC hours, we have a difference in the right side, which is highlighted in the orange. So instead of triage being called, we get called, and we see the patient right away within the 15 minutes or so, and then provide the dispositions, including the third triage option from compared with the traditional two, which is if we think we can downgrade the patients within 6 hours, we actually keep the patients under our service, even if there's a bed upstairs, and we're going to talk about that later too. And then if there's also no bed for the patients in the ICU, we're also going to take over the patient care. And then in terms of responsible parties for the boarding patients, we are responsible for these patients. Now, in terms of study outcome, okay, well, you talked about all these conceptual things, but what's the data? So we looked at the data, and we have 6% decrease in risk-adjusted mortality, which corresponds to 28.3% decrease in relative risk, and that corresponds to number needed to treat to prevent one in-hospital death of 17 patients. And if you look into the detail of the study, one thing we discovered is that this mortality benefit is not across the whole severity of illness spectrum at all. So just to orient you, the orange line represents the patient who came to the ED during non-ECCP hours, the morning, the nights, the weekends, and the blue is during the ECC hours, ED arrival. So the ECC SOFA scores, basically, the lower the number is, the less sick the patients are. So that's the kind of DKA patients. We don't make a difference in those patients' mortality. They have intrinsically low mortality to begin with. And it's not actually the sickest patients either. Those with the multiple organ failure, those are not the ones that we're making a difference. It's actually the intermediate severity group of patient that we make a difference, 12.2% mortality decrease. So why is that? Well, maybe that the triage fellow, before we start the program, is basically spending a lot of time in this top group of patients who are very sick. It's very obvious the patient's sick. They're all over the patients. And whereas the intermediate patients, they might not get as much attention from the providers. They're silently getting sick in your emergency department. So this is my last slide. Basically, as Namita talked about, this ED boarding increases because of the ICU being full and also more patients coming through ED that are critically ill, right? So what we try to do for ECCP is that we try to provide something to decrease ICU congestion by controlling the inflow of ICU from the emergency department. So one of them is minimizing ICU over triage. The second one is avoiding ICU admission when benefits limited, early goals of care discussions. But technically, these two things can be done without the ECCP, right? The third one is probably the most important, which is to increase early and safe ED downgrades. And hopefully, I'm going to have more time to talk about it in the second half of the talk today. But basically, whoever is too sick to go to the floor, but what we think is that we can actually downgrade them to spare this extra bed in the ICU, that can be used for future ED patients of yours or your colleagues who really needs the ICU bed. Otherwise, it's going to suck up a lot of resources from you and your ED. And then we also accept, unlike the Michigan program, we accept the fact there's going to be some borders. But we're going to try to mitigate the negative consequence of ED boarders by being selective as to who's going to be boarding. So if there's only one bed and you have 3 critical care patients in the ED, we have this bird's eye view to try to select the best patients to be boarding. That's a very important concept. And also, it's very important that we, as the dedicated providers, try to look after for them, because usually the ED is too busy to take care of other patients. MICU team is too busy to take care of their own patients too. So these boarders tend to have less attention than what they deserve. So whatever the model we use, we need to make sure that somebody whose priority is to take care of this boarding patient will be very important for a better outcome. Thank you very much.
Hi, I'm Willie Baker. Again, I have no disclosures, although I'm always hoping for one. I am not a critical care physician. I am an emergency physician. So like, what is this guy doing up here? This is a critical care talk. Well, I am an operations management, quality improvement, and clinical pathways guy. And I will explain to you why that is very important to this talk. Now, I do want to give acknowledgement to Caitlin Morissette and Skylar Lentz, who are critical care EM and are integral to a lot of what I'm going to chat about. So who are we? University of Vermont Health Networks, Vermont, right? That's in the name. So yeah, we do serve Vermont. We also serve a swath of northern New York called the North Country. And our hospital referral region is pretty large, and we are the only tertiary care center there. See that red thing sort of over here? That's Burlington. That's where we are. Albany is way down there. That's the next closest one in New York. And then Lebanon, New Hampshire with Dartmouth's down there. And those little teeny stars, those are smaller hospitals. A lot of them are ours. We have 6 hospitals, 7 EDs, and most of them are critical access. So there's 1 doctor, less than 25 beds or 0 beds, no ICU, and many of our non-affiliated hospitals don't have ICUs either. So this is a challenge, and for those of you that work in or are familiar with rural health, understand this challenge. So our catchment area is about 1.5 million residents. We have, as I mentioned, 6 hospitals, 7 EDs, only 1 tertiary care center. Only 2 of our community EDs have ICUs, and one of them is probably not the kind of ICU that you're most familiar with if you work in an AMC. There's no in-house critical care coverage at night. And we have about 45 patients a month that we deny access to our AMC's ICUs because we're full. And yet 1/3 of those patients were admitted and had a length of stay less than 24 hours, with half of them being less than 12 hours. So there's a theme there, right? You've heard that in my previous speakers, that we want to really limit access to our valuable ICU beds to people who are likely to be there for short stays. Pick your number, 24 hours, 12 hours. I'd love to know at some point what you guys think is the right number that you would keep that patient in your ER to save an ICU bed so that you don't have a really sick ICU patient boarding in your ED. Now then, what happens after they go to the ICU? Well, they need a ward bed. Some of them are discharged to home. So if I want you to take 2 things away from this talk from me, is if you want to really reduce your ICU boarders, focus on operations management, not just hospital flow, but system flow in your region, not just within your network, but the other hospitals. And that means you're going to have some people who are friendly in high places. So we have a regional transfer center, which the name of which we changed to the Care Coordination Center. And the top doc in that organization is an EM doc, and number 2 is one of our EM critical care docs. A little bit more about healthcare in rural regions. So this is the Dartmouth Health Atlas. So this little sort of light blue area is our referral region. And so you can see lower numbers of ICU beds, higher numbers are in the darker. And so in our region, we have amongst the lowest in the country. We're 1.3 ICU beds per age-adjusted population Montana is 1.8. So you think, oh, the Northeast, New York, big city, Big Apple, there's some pretty austere environments with respect to ICU availability. And then when you look at this map from the perspective of urban versus non-urban, you see some stark differences. Anybody who's interested in this, I love maps. Maybe you can get it off of the slide set or just email me directly. I'll send you links. So what are the approaches? So we did pilot a critical care transition service, and we really liked it. It was very successful. We did have to sunset the pilot for now, but we had some great successes. And this is a model of, you've heard a few different models. We didn't have, not only did we not have space in our AMC's ED to build an ICU, but we wanted to provide services to all of our network hospitals. And so this is truly an ICU without walls. So our EM critical care docs are on staff for telehealth at every site in both of our states and have full privileges, so in-person, face-to-face at the sites that have ICUs, but they're mostly based at our AMC. And so we didn't add any physical resources, no additional staff, again, no boundaries. They provided advice, did procedures at our AMC, and helped on transitions of care. They were ED-based, so they kind of sat in the ED during their shift. In their starting, they called everybody up, made the rounds. We did a lot of publicity. They did inpatient consults, teleconsults with other sites, teleconsults with hospitalists at other sites, collaborated with respiratory therapists, nurses, variety of callers. And in doing that, we did reduce inflow. We were able to keep reduce short stay ICU admissions and overall reduce the demand on our ward beds. Because as mentioned before, and those of you who work in ICUs know, a lot of your boarding problem in the ICU is because you can't get a ward bed to send someone out. So what are some of the other techniques? I talked about flow. So inflow and outflow. So in reducing inflow, you're not just reducing your ICU inflow, you're reducing non-ICU inflow to your AMC, because those patients are going to need a ward bed, or they're going to take up a bed in your ED or your ED-OBS unit. So we do that through care coordination, the Care Coordination Center, because calls coming in to send someone to us go through that center. We work on evidence-based guidelines, and we have like a whole library of them now. I'd love to talk about them, but Namita said we have to save a couple of hours for some chit-chat afterwards. But I'm real excited about some of the stuff we do, like MBIG, spine fracture guidelines, GI guidelines, other things. And the call comes into our regional transfer center, the CCS. They deal with a nurse. If they need to speak to a doctor, it comes to my phone working in the ED, or Rich Bounds if he's working that shift, sitting in the back. And we do procedure and returns. So we coordinate a patient coming in. Those of you that work in AMCs, there's somebody who's septic in a community ED, they don't have IR. They come in, we do the procedure, we return them back. So those are some of the tricks, techniques, ideas on controlling flow.
So thank you. So you heard about our different ways at our individual institutions of how we have brainstormed and tried some innovative solutions. So I want to pause it here and just see, are there any questions for any of our panelists, or any comments, thoughts? Love to hear your own experiences.
Thank you all for sharing your experiences. Wendy Chang from University of Maryland, EM Critical Care. I guess just for a little bit better understanding on the pre-states, because we heard a little bit from Stanford that prior to implementation of their consultative service, the MICU team did assume care. At the other sites, though, did your critical care admitted patients, were they cared for in the ED by the ICU team, or was it still ongoing until they physically got a bed prior to each of the solutions?
That's a great question. So I can speak for Henry Ford. The emergency department has always cared for our boarders. So care does not get assumed until the patient arrives at the unit. And you know, like the design when we weren't busting at the seams was certainly there's a lot of educational value. We have a large residency. There were a lot of historical reasons why that worked out, but you get to a point where now the balance has tipped. And so the solutions then are, in some ways, they're responding to the needs. And so it was really important for us to do that needs assessment and understand that maybe we don't necessarily want to change the model of the handover, because the reality is the hospital teams are just as strained. And so remote care is not necessarily more ideal for the patient. So having the ICU team remotely care, we're not in a situation where we can add personnel. So that analysis was how we landed on a more formalized, structured approach of that Monday to Friday, 2 to 10.
Yeah, at Michigan, we were the same too. We were taking care of patients in the ED, and it was frustrating. You would call the ICUs, and they would say, "Give another leader, give 2 more leaders, call us back in a few hours." And we were finding that when we looked at our data, our patients were staying in the ED before transition to the ICU at least about 6 hours on average. And so when you look at the national data in terms of negative outcomes, as you're all aware, 6 hours was kind of the inflection point where mortality starts increasing. So we knew we had a problem. We had to do something different.
Well, it's the ED team that takes care of them at all of our non-ICU capable sites, for sure, as well as at our ICU capable sites. Except during our pilot, the EM critical care docs would assume care. And since we're all on Epic, when they're doing their telehealth care, we can see everybody's chart, just like looking at your own chart, and they could assume part of the care, but of course in person physicians have to.
In the meantime, I'm just curious, how many of you have an ED team taking care of all the ED ICU boarders? I'm just curious. How many of you get the ICU taking over? Oh, interesting. Thank you so much.
Hi, Matt Stoll, Prisma Health in Greenville, South Carolina. EM intensivist as well. What I'm hearing from at least 2, maybe 3 of the models is that EM critical care is playing a role in the hours that traditional critical care isn't interested in continuing to be in the hospital or care for patients. Within the era we're seeing of burnout and trainees deciding to potentially choose additional training to free up options and maybe have a little more consistency in their lifestyle, do you see that as a sustainable? EM critical care is a young field, let's be honest, right? Most of us are 10 years or younger in our careers, at least from the more formal pathway that's been around. How do you see this changing? I have colleagues who don't want to work 2 to 12 always, or nights always. And so I'm interested if you see a future or way to expand this to be equitable with our colleagues upstairs.
That's a great question. I'm 50-year-old and I'm feeling the impact of working into midnight because you don't go home until probably 1 o'clock in the morning. So it's real, but when I created this program, it was very important that we're not really stepping on the toes of our ICU colleagues to make it doable for them to accept this proposal. And the most important thing is the patient care. So it just happens to be that the need of the patients are on those hours. Having said that, we made some adjustment. For example, instead of going through all these new consult or admission requests until midnight, we stopped taking the new staffing at 11 o'clock. And then after 11 o'clock, new staffing is going to be done with on-call attending by the fellow. So just try to reduce this kind of a extensive time beyond the shift. Of course, it's not going to solve the issues, but that's just one way to do it. And I think we have enough young folks with EM critical care backgrounds going into this field, but people like myself, if it gets really too hard, I might, potentially adjust my schedule to do something else. So I think that's definitely a possibility.
Yeah, that's an interesting point. And so for us at Henry Ford, our intensivists are also working around the clock. So they have had to expand. So on the ICU side, I also have a swing shift when I'm in the ICU. It's 2 to 8, and we have nocturnists in-house. Our demand for ICU care, so our nocturnists, they're covering 64 medical ICU beds. And so the demand is there. The ability to expand the staffing is still kind of challenging. But I think more importantly, what happens is there is still a little bit of that worry and fear from non-EM intensivists, both for coming to the chaos of the emergency department. And I'll be honest, I think it throws everybody off. And so EM intensivists are suited to make that balance of you've got the ICU longitudinal care expertise, you are comfortable, familiar with working in the chaos of an emergency department. And so there's a little bit of a comfort pull. And then there is still, I think, some territorialism amongst other intensivists. So when designing and implementing the model, there's some of the hospital politics does need to be taken into account. And so similarly, it's kind of like we had that experience of we're going to ease into it. There's the opportunity to expand. There's nobody knocking at their door going, I'm a pulmonary critical care physician. I want to do EIT shifts. There are fellows, the fellowship. They love our rotation, so they're getting that educational experience. They appreciate seeing the early phases of critical illness. It's a very popular fellowship rotation. And so I find that a lot of our EM critical care graduates, they're coming out, they're actually in Michigan having a little bit of a hard time finding ICU time. And so having some opportunities for different models, I think, helps support the increasing the growth of our subspecialty. And then the last comment I'll make is similar to what Yoshi is saying. There's opportunity to build in some wellness into the shifts itself. So our selection of 2 p.m. to 10 p.m. was intentional. We didn't want to cross over 2 meal periods, so you get to have your lunch and then start your shift. We stopped taking consults at 9 p.m. to try and get out at 10 p.m. So that's the way we tried to design it that way. Yes.
Yeah, I think, Matt, obviously it's a great question. Full disclosure, Matt was with us. We lost him to greener pastures, no pun intended. I think I think we have to be very strategic in emergency medicine, right? Because we're putting out a lot of graduates now into EM critical care, and unfortunately, like what Namita said, at our institution, certainly we have an issue where people don't know what we do. They don't understand, they don't look at us as your stereotypical critical care physician. And so it becomes hard for them to get those inpatient positions short of the overnights and the unpopular positions. We're building a brand new tower. There's going to be a lot of overnight coverage that's necessary. And we find ourselves trying to chip away and get into the call pool of, these unpopular shifts. And I can see where that's, a good way to get our foot in the door until we establish ourselves and prove ourselves. And certainly I think the folks that have had inpatient time have certainly proven their worth, and there's more interest to get more people like them. But I think we're still in this phase of, people just don't understand what we do. And so we need to be cautious of that, I think, as a community. Cincinnati is interesting in that because they have an inpatient ICU, they did open up their staffing to both EM intensivists as well as pulmonary critical care and other intensive care. And very quickly, those folks that came into those realms realized they don't enjoy it as much as the EM folks do, because it's just a different way of tackling problems. The fast pace, the fast turnover is not something that they're used to. And so I don't know how successful we're going to be of getting non-EM critical care folks into our models, but I think we just need to be very strategic about how to get our folks into, the established models upstairs.
Can I just ask out loud? Can I ask a clarifying question for those of you that transition? What happens when you leave? I guess my question, do you, there's obviously the ECCP model of their 24/7 care, but at 9 p.m. you stop taking consult, at 10 o'clock you're gone. Who cares for that patient that's boarding? And have you looked at that data to see if there is a rebound of mortality or anything like that once you leave?
That's a great question. For us, because we're a consult model, so we're not really officially taking over. We're even during the shift, we're supporting, and so it just goes back to the primary. It's like it's a handoff. This is what's happened. Here are the updates. We update the sign outs. So our standard shift, the midnight shift comes in at midnight, and so we try and update everything. But it's a standard. EM is still primary.
We are management model as well, so we take over. But what happens is that we involve the triage fellow early so that they're not hearing about this patient for the first time at the transition point. And nowadays, actually, we switched the model to the extent that instead of the ED calling the ECC attending, they actually call it triage. So everybody in the hospital calls triage fellow. It's just that we make sure that the patient gets seen by somebody. So if the triage fellow is too busy, I go there to make sure patients get seen right away, which is very important, by the way, for the patient outcome.
And I will say, I think that's an essential piece to work out in the design phase, because you do need to make sure that the patient has some sort of continuity. And so that's, I think, when designing these different models, that operational piece is so key.
Hi, I'm Abel Wakai. I'm an emergency physician in Dublin, in Ireland. So I work in a completely different system where emergency medicine, critical care specialists are even less developed than here. I think that's only one in the whole country that I know of. So our care of this patient cohort is even more basic. Our needs are more basic than yours. And I think emergency medicine, nursing, critical care is actually a main challenge, sort of recruiting and retaining nurses in the emergency department with critical care skills, willing and able to take care of critically ill boarded patients in emergency departments. So I'm just keen to hear your experience about emergency nursing, critical care, training, retention, recruitment, and whether it's a challenge for you, because it is a challenge for us.
I think that's great. That's a fantastic question. I think Namita could have helped you while in Ireland, right? You were there for 10
Abel
years.
and I work together.
Oh, perfect. Yeah, it's interesting. We were worried about that. We uptrained a lot of our nurses that had an interest in critical care. We sent them to different ICUs throughout the institution, and they got the requisite knowledge, and then the vast majority will now work mostly those shifts. It's a very, very popular place to work. So interestingly, we've not lost nurses to burnout or to other units. We've actually lost them to things like they wanted to become an NP and increase their skills and then start practicing independently outside of our walls. And so we look at that as a success. And there's always a large list of junior nurses that want to come and train and work in this environment. It's kind of an interesting beast, right? It's people that are very interested in the fast pace of emergency medicine, but want to take their to take their knowledge to another level. So we've not experienced the challenges of losing those nurses, which has been good.
I kind of touched upon this really bit earlier, but basically it's much more efficient to train a few ED-ICU trained nurses, and they supervise primary ED nurses. That way you don't have to train all these hundreds of ED nurses to take care of the ICU patients. So that's one thing I'll say. We do actually have a lot of turnover, though, for those ECC nurses, because they're so skilled. They're basically needed in many different parts of the hospital and healthcare system, so they're very hot commodity. But they actually always have this reservoir of the nurses. So they are per people who basically do part-time of that, because they have to apply for the position, and they get to do a little bit of it, but the majority done by the full-time nurses. So when somebody leaves, those people who are just doing a little bit of that gets promoted to that position. So there's always going to be continuous inflow to try to keep that things to be going.
Yeah, I think, that's a really interesting question, and we don't have necessarily nurses attached to our model for EIT, but what we do is we have a high complexity of illness. So all of our nurses, when they come to work in our emergency department, they're getting training specific to management of critical care. So there's some structured programs. I think it's a TNCC is the program that our nurses go through. It's trauma and critical care specific training. They really enjoy working in Cat 1. So there's this dichotomy. When our high acuity is a draw for retention. Where we lose our nurses is related to workplace violence. and then the delivery of like the social care. So the crowding, that really it weighs on our nurses. So the moral injury is what's leading to more of our losses. But there is a variety of interests. They love working in the high acuity. It's fast paced. It's I find that when I'm on, because I have a little bit as an EIT physician, I have more time. I'm not primarily trying to teach the residents. I'm not running between resuscitation. So I'm often at the bedside, and I can walk through. And what I do is try and explain everything. And there's such an eagerness to come and learn, and they like use us as a resource for their own learning. So I think one of the retention strategies I've noticed that's leveraged really well here in the U.S. for nursing in general, and especially at Henry Ford, is actually the professional development opportunities and structured. And admittedly, I used to work in Ireland, and I left, it's been like 13 years now, so I don't remember, but what I do notice that the nursing staff here at Henry Ford is annual competencies. So there's the opportunity to continuously add and teach and focus. And every year we look at what else needs to be added. So a couple of years ago, we added a sepsis module specifically for the nurses, and we added the critical care module. So we have really good nurse educators and clinical nurse specialists that are continuously looking at the landscape of what's changed over the last year, and then they adapt. And so I think that has worked quite well for that retention.
I agree with that, actually. We do have critical care education day for the residents once a year. We actually invite those ECS nurses. They basically say the reason why they stay there because of the education that we provide. So the education is very important for the retention.
So I wonder, Jamal, I might have you talk to some of your experiences on the outcomes of the EC3 model, just to kind of give us a sense of the impact.
Yeah, I mean, I don't want to belabor too much of the point, but it's been, the last 10 years have been incredibly successful. Oh, thank you. Ed mentioned we'd kind of had a massive reduction in ED to ICU admissions. A lot of those admissions we were noticing were 24-hour stays, which is kind of like the bane of our existence because it takes so much time to turn over those beds. And so we were noticing that we were losing a lot of time there. That's allowed our ICUs to bring in other patients that were critically ill. You know, we've had substantial success, as Yoshi was also mentioning, in the DKA population. I mean, the vast majority of those patients would come into the hospital. Now a good chunk of those were being discharged home. We've published a lot of work on things like, you know, being able to extubate patients within the walls of EC3 safely. The minority of those patients are now admitted to the ICUs. You know, our time to critical care has dropped significantly in the ED. We've had much more patients that have gotten to their level of ICU care within 6 hours. We've created some protocols around intracranial hemorrhage where, you know, all of those patients used to go to the neurocritical care unit. Now we're actually taking about 75%, not sending them to the unit, and about 25% are being discharged without ever having an inpatient stay with their intracranial hemorrhage. So just across the board, we've noticed, you know, marked success in any of the disease processes that we've been able to tackle by having a dedicated unit with dedicated people taking care of those patients. And again, the question when we started all this was, can you do that without spending a ton of money? And, you know, thankfully, the value proposition is certainly there. It's not increased the overall cost to patients or to the system, short of the actual space. You know, that was a big investment in terms of the space and designing the space. But, you know, thankfully, a lot of that came through philanthropy, which was really good in our case. But once we had the unit going, it's been showing financial feasibility. Yeah, Matt.
Maybe a controversial question. Obviously, the philanthropy was an important piece of the Michigan model. There is at least one other ED-ICU that I know of that was stood up and has already closed. Is this a sustainable model without the inflow of like massive capital to have the space, I guess, is my question. Or even the human capital, we're talking, I imagine, all of your budgets are multi-millions for provider level care. So, you know, I don't see a lot of, I'd love to see the ROI on that, I guess is my question.
Yeah, I love the controversial question. I'll maybe answer my thought on it, and I'll pass it to my colleagues. But yes, as you know, in EC3, as we were kind of trying to figure out how to say that this was financially feasible, sometimes at the beginning we were looking at a lot of fuzzy math, saying, well, yes, it costs a lot of money, you know, if you look at it as purely ED stay, but it saved the institution a lot of money in terms of the, you know, additional ICU beds that were available, things like that. And that fuzzy math only goes so far, right? It gives you some time. So that was challenging for us. Flex ICU in Cincinnati, they didn't want to release their financials just yet because they're still analyzing, but they did give me the green light to say that they're actually, they're projecting that they're making more money than they expected, and they're a net positive. So I think when they actually release their financials, which they plan to do at least the 1 year mark, it's going to be a success in terms of building these specific units. They said there's something like 4% ahead of where they expected to be, which is surprising because, you know, that too was the thought was, are we going to lose money on it? A lot of it is just making sure that the beds are filled, and they're doing a very nice job of filling their beds.
I think when you're, and it goes back to that design and implementation, it's got to be, you got to think about what's the financial model, like what is feasibility. For us, we didn't have the geographic space, much like what Yoshi was saying. We can't expand the footprint. We're stuck in the midtown Detroit, can't grow. We have a need, so we have a continuous influx of critical care patients. We don't actually even get to see all of the patients. Our break-even, we're just pure critical care billing. So it's all under the emergency department. We're just doing just critical care billing. Our break-even for that, because we're split, we're not hiring any full-time. It's, we're all split between the two departments. We need to bill 3 critical care notes to break even. That's all, yeah. So the personnel-based model, much cheaper than the geographic, and it takes out that capital. Now, we don't have a team, though. So the impact on the patient is going to be, we don't have the critical care nurse, we don't have the respiratory therapist. And if you think about ICU interventions, truly it is a team-based sport. And so there is that drawback in that.
The finance is very important. So we actually have a local uniqueness where we don't only take care of medical patient, we have post-op patient that comes to our medical surgical ICU. So it was a reliable source of income for us. So you use that to basically take care of our mission, basically, you know. So basically, I basically figure out if we take care of 4 critical care billing per day per shift, it's going to be for us financially float. We actually make enough money because we're not paying, yeah. Because we're not putting any pennies for anything because we're using existing infrastructure, RT, pharmacy, nurses. They are all in ED already. So the only thing your cost-wise is going to be just the ECC attending salary. But we make enough money. So even for the COVID, even when we have expansion of the hospital, so we don't have as much board in ED and all that, we have enough business upstairs to be always making more money than our cost every single year since the 2017. A lot of actually. So basically, it's very important that whatever the system you're going to use, you have to basically look at the local needs and local uniqueness and see what the financial model looks like to make it reasonable for the leadership upstairs.
We're about at time, but and I could talk for a long time about revenue cycle. I'll ask you all to look ahead where the puck's going and not at your RVU-based compensation now. We are all still compensated in RVU-based compensation model. You will lose. We will all lose in that model. And ICU care is really expensive. And the stuff we're talking about today is much cheaper, particularly we're targeting patients who have short ICU stays. So think of it in those terms. Do whatever you can to learn about reimbursement in medicine and how we're losing and how we can actually regain our control of the system. And it's not on, we're money losers. And actually, Pulm Crit is the worst. If you write me, I'll send you some information on it, on some Scintillus KPP reports. But on average, the average physician costs 1.4 times what the revenue that we generate in our RVU-based system in America. So forget the RVU-based stuff for the future. Work on it now because that's how we're paid. But think about how we're going to add value to healthcare.
That's a great way to wrap this up. We are going to be available if you have ongoing questions, but to respect the next session, we'll wrap it up. We hopefully gave you a little bit of expertise on how to brainstorm and think about implementing some innovative solutions with models of critical care. And please feel free to reach out to us if you have any other questions. Thank you all for joining.